we start our lecture today, I would like to read a few of Zoom etiquette for all the audience. Maybe if the admin can, okay, thank you, Doctor. First of all, the rules for our lecture this morning. To all the audience, please mute your microphone during our lecture. And if there's any question, you can raise your virtual hand and speak after you are permitted, or you can fill the chat box. And do not forget to fill the attendance form. Before we start, I will read a little bit information about Dr. Saleh Jany as our guest speaker today. Dr. Saleh Jany is a faculty member at the Paramedical Community College from the Greensboro, North Carolina. The education background is Master of Science in Public Health from the Milken Institute School of Public Health from George Washington University. He has higher diploma in Letter in Medicine from the University of Baghdad. Master of Science in Maxillofacial Surgery also from University of Baghdad, and Bachelor of Dental Surgery from the College of Dentistry, University of Baghdad. There's a few membership that Dr. Saleh Jany has. He is a member of the Royal College of Surgeons in Ireland. He is the member of the National Dental Board of the American Dental Association. He is also a member of Diploma in Oral and Maxillofacial Laser Surgery from the American Board of Laser Surgery. And he is a certified medical laser safety officer from the Laser Institute of America. Dr. Saleh Jany, how are you?
Alhamdulillah, thank you. I'm good.
Okay. I would like to give you the time to speak and start the lecture.
Thank you. Assalamu alaikum. How are you? Hopefully you can see the PowerPoint.
Yes.
Okay. So it's a dental extraction. It's a very common procedure. All dentists should know about that. It's a bread and butter for every dentist, and they start when they are juniors and continue for the rest of their life, unless they become specialists. But even they have to know about dental extraction, and unfortunately, we have to extract the teeth. Teeth are very vital and very important for the function, living, and normal living of the oral and the maxillofacial area. But sometimes we have to extract them to prevent further damage to the adjacent teeth. Further damage or infection or abscess can cause damage to the bone or adjacent teeth. So always we think about healing, that you should know about healing. The body always has capability and ability to restore itself and try to become normal. And there are two types of healing. There's primary intention, when you have a clean cut on your skin and there's no infection, and there's the edges of the cut, the cut and through the skin, they are edge to edge. That's called primary intention. But if there's a gap, there's missing tissue, it leads to secondary intention and a scar. Unfortunately, missing a tooth, when you extract a tooth, it never will be the same again. When you lose the tooth, there will be a gap because that tooth occupied that gap. And the bone, although sometimes you can put bone graft, you put biological membrane to protect the bone, to help the bone to grow back, but will never come back again a normal function, and you will lose the periodontal ligament forever. Tooth extraction is a body shape. It's like sequence process. You will know about that. And start by blood clot, and blood clot will become fibrous and become granulation tissue, and the bone will regenerate and remodel. Some thought about for young dentists for tooth extraction. You should think about a patient as a patient, it's not a tooth. Always take your time. Don't rush. Always take X-ray. X-ray now available. If you have a chance, you can take 3D X-ray. You can see where's the nerve, where's the root, the curvature of the root, the adjacent teeth. If the you have to look if they have large, the adjacent teeth has a large fillings, or the adjacent teeth has a crown, or adjacent tooth is a dental implant. And you have to study the case. If you think you cannot make it, you could refer it. There's very nice oral surgeon or colleagues, they can help you, and you can always have monitor. You have your professors, you can ask them, you can send them the picture, the case, and don't rush for if there's a difficult case or you anticipate the complication. Always listen carefully to the patient, and if they have medical history, if they have history of bad or very difficult extraction, always look for the opposite teeth. Always think about the future. What you're going to replace that tooth with? You're going to replace it with the preferably implant or partial denture or bridge, and try to minimize trauma to the bone is what's the most important thing, to the gingiva, to the adjacent teeth, and always think about make the patient comfortable. Give good anesthesia. Anesthesia is not expensive. Give them good anesthesia, anesthetize all the area, take the time, and look for the numbing, take on, and there's no pain. And always talk to the patient, make them comfortable. Don't get nervous, because the patient will be scared when they see you scared. When you're nervous, the patient will be nervous too. And then don't use too much force. Extraction is not a force. You know where to push your, when you put your pressure, when there's leverage. And it's not a traumatic. It's not you're destroying a house. No, you're removing a diseased piece inside the jaw without damaging the jaw, without damaging adjacent structure. A traumatic extraction is much better for the healing of the patient, for your confidence, for the future of the patient will come back to you because they have less complication. And also for the future, if you can replace that with implant, or you can replace it with bridge, or because you have a good bone, you didn't damage too much bone. When you have wisdom teeth, one of the many people scared from wisdom teeth. But I will tell you, wisdom teeth, if you extract wisdom teeth, the patient is 18, it's not very difficult. But if you have a patient 40 years old and you have semi-decay wisdom tooth, that's very difficult when you extract the wisdom tooth. Sometimes a wisdom tooth impacted inside the bone will cause no problem. Just follow up and take X-ray every few years and just leave it, and just for follow up, because technically they will cause no problem. There are many factors influence tooth extraction. Blood supply. That's why a blood supply is very important. Good blood supply, the healing will be faster. The age is very important. Younger patient will heal within a week. They don't have any complication within the second, third day. They don't have any pain or discomfort or swelling. Older people, they will have more more swelling, more complication. Their physical effect, like traumatic extraction, will heal longer time than a traumatic extraction. If you use handpiece, if you want to use handpiece to sectioning the tooth, if you want to use handpiece with to remove a little bit from the bone, which is contraindicated, but sometimes dentists, they use the handpiece to use a lot of water, use a lot of suction, because the heat will damage the adjacent structure, especially the bone. The bone now is very precious because most of the treatment now is one of the best treatment is implant. An implant need a good bone to osseointegrate in. Also, the general factor, patient with diabetes, or they taken steroid, are anemic, they will have delay healing, and they have more chance of infection or complication. Systemic condition, as I said, if they have a background of systemic disease, they have more chance of infection. Poor oral hygiene, they have more rise of infection, intraoral infection, and delay healing. People with hormonal imbalance taking steroid, they will have delay delay healing, and sometimes even they can have infection. Pregnancy healing will be will be delayed too. Other factors, if you want to keep the blood clot, suturing is one of the good things that can help healing faster, because suture will be like a base for the blood clot and protect the blood clot and scaffold the blood clot and help in healing. There's many reasons for tooth extraction. Trauma. Younger people, they have more chance of decay, but over 40, they have more chance of periodontal disease, and they have gum disease. So you can say the chance of gum disease will happen over 30, and chance of decay will be on younger people. And back to teeth, if they can cause problem, you can extract them. If they can cause resorption of adjacent teeth, you should extract them. Sometimes you do extraction for orthodontic treatment. This patient, one of them trauma, the other one, they have severe periodontal disease and damage. You can see the root is exposed. Other causes can be tumor. This case of in the maxilla, the squamous cell carcinoma of the maxilla can cause you have to remove the teeth with resection of the tumor. Or can abscess. Abscess can usually, if the root is lower than attachment of the the buccinator muscle, the abscess will go underneath with submandibular, you remember, space, and can cause sinus drainage. So one of the treatment, you can give the patient antibiotic, but if the tooth is still there, the infection will come back and the sinus drain come back again. So extraction is not a force. It's not only a force. One lecturer, they said when you use forceps are being used for many years. Try use less forceps. Use very small luxator, dermatome, periotome, and use just to separate the soft tissue and periodontal ligament around the tooth without damaging the adjacent structure. Don't damage the socket. Don't squeeze the socket. Long time ago, they learned you have to squeeze the socket because the treatment is partial denture. So when after extraction, you squeeze the socket to prevent the undercut. But nowadays, you have to protect the socket as much as you can. Protect the crystal bone, the bone that will eventually heal to create some bone. The healing of the socket, there's granulation tissue and the bone from the inside, from the inner part and lower part of the socket, from the apical part of the socket, and the granulation tissue will grow from the gingival part. But usually the granulation tissue is faster than osteo tissue or bone tissue. Some dentists, they use bone graft and they use membrane to guide the tissue regeneration. Sometimes they call it GTR, or guided bone regeneration, GPR, and to give a space for the bone. The bone needs scaffolding. So the scaffolding usually either autogenous bone or external bone. You can put the bone fragment, you can put it there, and you suture it and help the regeneration of the bone. And alveolar bone in general, some people, they call it temporary bone, because the alveolar bone, if you lose the teeth, the alveolar bone will shrink to become basal bone. And I have a case patient with anodontia. Anodontia, they don't have any teeth when they're born. So she doesn't have any alveolar bone, because alveolar bone will grow with the teeth. And when the tooth grow, the alveolar bone will grow around it. And unfortunately, if you extract the tooth, the alveolar bone will shrink, especially if you don't replace it with implant or even denture or partial denture. When there is a stimulation to the bone will grow or will maintain its density. There's also said if there is loading around the bone will get strength, remodeling, and thickness. If there's no loading or decreased loading, the bone will weak and due to reduced remodeling. So that's why it's even not only the teeth. Imagine somebody, old patient, lay down in the bed for weeks, and suddenly when they start walking, they will have hip fracture, or they fall on their and they break their leg because the bone is so weak. Because if you don't use it, you lose it in general in the all tissue and the bone specifically. I want all the students to learn sectioning of the teeth. Usually, multi-rooted teeth, especially lower molar has two roots, and upper molars they have three roots, and usually the roots are diverged like that, and the crown of the socket opening will be smaller than the root. So you always think about sectioning the root. So you have to know, even under your supervision of your teacher, you learn how to section the teeth, because sometimes you have to dissection the teeth after the crown will fracture. But the best way, you think ahead, you took x-ray, you can see the root are diverged. Let's start sectioning before you fracture the crown during extraction. And there's many ways to find the bifurcation or trifurcation of the upper. You just reflect the gum and see the bifurcation. Now you start, where is this? You can saw sectioning, and you start cutting until you reach the interradicular bone, and then you can see that there's a bleeding there. And then you separate these two roots or three roots in the upper. Usually upper palatal root rounded, so you can, if you remove the palatal root first, it will be easier to remove the meso and buccal root in the upper molars. So I advise you to train how to section the teeth, because it's one of the way to help you very difficult cases. I'll show you this case. There's a fracture upper first premolar. It's one of the common premolar to be fractured, but one way we can, and always learn how to make flap. This is two-sided flap. You make a flap, remove the bone, and you remove the tooth. But you can do this one, you cut the crystal bone. But if you can, without damaging the crystal bone, you make just a window hole, and you remove the root. And in this case, we kept the crystal bone. The level of the bone is still there. So if you fill it with bone graft, or even without filling bone graft, you will have more bone than the first case when you remove a lot of bone, especially buccal bone. The palatal bone is stronger than the buccal bone, and the blood supply of the palate is higher than the buccal bone. That's why if you extract all the teeth in the maxilla, you can see the shrink of the maxilla go palatally, and the maxilla gets smaller when you treat people with the complete denture, while the mandible, the resorption will go forward, downward, and the maxilla will go backward, palatally, and upward. So always think about the bone, because always think about the treatment. What are you going to replace that? So the buccal bone is very important and precious for the treatment. So some books, they said these times, some books said 3 days happened, that 1 week will happen, but every patient will be different. But this is a general idea. So a blood clot will start on the same day after extraction. You will have a bleeding from the socket, from the periodontal ligament, from periosteum in the area, and the blood clot will happen in the first day. Within 3 to 4 days to a week, we'll have the granulation to start, and the primary osteo, the bone formation, will start within a week, but the mineralization will continue from 3 weeks to 4 weeks, and then start the primary bone, then trabecular bone will happen within 3 months. But these 3 months will be different from patient to patient, and even between posterior teeth than anterior teeth. Anterior teeth will heal if they have a smaller socket. They heal faster than if you have multi-rooted molar tooth. So the blood clot starts within hours, hemostasis when the bleeding stop within the first day, because the blood clot will grow and try to fill. There is always ooze underneath it. And there's always, whenever extraction is is a surgical trauma, excuse me, inflammatory response. There's always inflammation response. And the granulation tissue star formation, and then epithelialization and bone remodeling. And eventually we have socket healing. So the first tooth extraction, there will have a blood clot. After blood clot, and this blood clot will mature enough, and suturing can help stabilize that blood clot. And the first day we try, ask the patient, drink cold, soft food. Don't drink through straws. Avoid smoking. Avoid spicy stuff. Anything irritate the tissue, or destroy the blood clot can affect the healing. So within first week, we will have granulation tissue, fibroblast. Fibroblast is fast than osteoblast. That's why always we have competition between the bone generating tissue and granulation tissue generating tissue. Fibroblast is faster than osteoblast. And in the bone, we have osteoclast, but we don't have fibroclast. So the bone can remodel itself, while the fibrous tissue will continue to grow until it reach contact inhibition and it stop the growth. So that's why maybe we'll give you one lecture about guided tissue regeneration and bone growth. But the blood clot will act like a scaffold for healing process, and the fibroblast and cell migrate through these fibers. And slowly, the blood clot will be replaced by granulation tissue, and the first bone will resolve is the crystal bone, the crystal part of the bone, because of the stimulation of the immune system and stimulation of osteoclast. Within the second week, almost the blood clot will be very small. Even the color of the blood clot will be changed from to less red and usually gray, and the epithelialization start. In some anterior teeth, almost all epithelialization because they're very small. In the posterior teeth, the blood clot will take longer time to be replaced. And sometimes if there's a fragment or necrotic bone will stay there, now it can be resolved, or sometimes sequestrated will, sometimes the patient will feel it. And so it's almost always when you do extraction, clean the area, clean all the granulation tissue, irrigate the socket, remove all the fragment, because you don't want the patient will come back and tell you, I felt you left a piece of root there. It's actually is a fragment of bone. And he always explain to the patient, always take x-ray before and take x-ray after. You can see there's nothing there. So their osteoid tissue will start in the third week, whereas the bone will grow and the epithelialization will continue. And after the fourth week, the bone will get growing. Now, I think with the fourth week, you can see a little bit of the growth of bones in the x-ray. Before that, the bone, there is a bone tissue, but they are not fully calcified to be visible in the x-ray. And the bone will change with time with the remodeling, especially if you have a bone graft. If you did immediate bone graft, you will have more more stimulation, and hopefully you will have osseointegration with your new implant. So within 4 months, the movement bone changed to trabecular bone. But this is 4 months, maybe 3 months on the lower, 4 months on the upper, and depends on blood supply, the age of the patient, and the vascularity of the tooth has very vascular area. We have the blood supply from the gum tissue, from the periosteum, endosteum, and from periodontal ligament. And there's difference between the tooth and the natural tooth and dental implants. There are big difference. So I can tell all for young dentists, almost always, if you have to make sure to protect the tooth is much better than make implant. The tooth, it's a natural tooth, it's have a periodontal ligament. The implant is osseointegration. It's physically anchor inside the bone. There is a sensation if you have a food fragment in between your teeth. Immediately you will feel it. Which tooth is that? While that's proprioceptive sensation, you will lose that when you extract the tooth, and you don't have it. So that's a bigger problem with when you have implant or full arch of implant. You cannot control the force, and so one of the failure of implant is fracture because of the force of the patient will exert much higher force when if they can do as they have teeth. If they have teeth, they will feel the force. While the implant, you don't feel the force. Other thing, if you make a crown, is a little bit higher than occlusion higher. If you put it on the tooth, a tooth with the periodontal ligament can adapt to a little bit higher because there is a slight movement. There is always adaptation. There is always regeneration regeneration of the bone. While if you have higher spot in the implant, sometimes the patient don't feel it and can cause a fracture of the implant later. The tooth has also sensation. The implant doesn't. The tooth has more blood supply than the implant. There's real attachment between, there's a ligament, and there's a gingival attachment, and there is a gingival sulcus attachment to the enamel, while the implant is not. So the implant have more chance of what a periodontal disease we call it, pre-implantitis, than natural tooth. Natural tooth has more stimulation. Dental implant doesn't have a periodontal ligament. Natural tooth has slight mobility, which helps in the in the sensation. And natural tooth will stay forever if you have a good health, if you have good maintenance. While although dental implant doesn't get decay, but they have more perimplantitis and fracture of more fragment. There's many superstructure can cause a problem, especially if you use cement, and cement has another problems. So the blood supply for the tooth is much better than periodontal ligament. The blood supply with the tooth has much better than implant, and the implant within a few years you will have a resorption, and you will have a gingival recession, and within 6-10 years you can see there's almost always we have gingival recession. That's why you need good oral hygiene, good follow-up when you do implant. Let's talk about complication of extraction. One of the most common complications is dry socket. There's many theories about dry socket. Some of them, they said it's smoking, dislodgement of blood clot. But I think some of books, they said it's a trauma from extraction, and there is a stimulation to the plasminogen, will change to plasmine, and that's plasmine can destroy the blood clot. But it's multifactorial. Some people with the oral contraceptive, they can have more chance of dry socket. But in generally, I've seen if you have a good oral hygiene, less traumatic extraction, will be gentle, give the patient mouthwash, rinse before extraction, because one of the theory, they said some type of bacteria, alpha bacteria, can cause the disintegration of blood clot. But whatever, if you have a good oral hygiene, you have good educated to the patient and protect the blood clot, and if you have suture, you have almost eliminate the chance of dry socket. Dry socket, if you have dry socket, it's very painful. Just educate the patient. Always you can call the patient after time. If you have a major extraction, just call them after the second day, third day, and ask about them. If they have dry socket, you can bring them to your clinic, irrigate the area, clean or necrotic tissue or disintegrated blood clot, but surgery, whatever, sedative, sometimes regional. Some people, they hate regional because it's sedative, but it will delay the healing. But whenever you do, it will relieve the patient pain. It's better. But in general, dry socket will heal by itself because granulation tissue will grow and protect the area. But you don't want to get that headache. So prevent the dry socket is much better than getting dry socket. Infection, one of the common cause of after extraction can happen. Sometimes this infection happens because of the needle. Sometimes if the patient have a dirty mouth and you inject the needle, and especially the upper, with your needle can introduce the bacteria from the intraorally to the tissue spaces. That's what happened here, nasolabial tissue space, and can cause that infection. So, and always give the patient, if they have this one, give them antibiotic. But before that, if you have good oral hygiene, give them mouthwash before extraction, clean the area, irrigate that area, then give injection, and try to give injection slowly. Don't give the injection as fast as you can. Just give a little bit in the gum, and it will heal it will numb the gum first. Then you're going to get deeper to anesthetize the area. And the infection can be poor oral hygiene, systemic disease. Usual infection in the socket will heal by itself, but almost always give them antibiotic, because you don't want, especially in the here, dangerous triangle, you don't want to get infection here. It can cause to cavernous sinus thrombosis. It is very rare, but you don't want to get that. Prolonged bleeding, it can happen with people with abnormal bleeding conditions. I had patient with hepatitis, and then they have a bleeding because they have liver disease. When they have liver disease, they have less clotting factors, so they have bleeding. So sometimes you never know the patient is a bleeder, but sometimes the patient, they take in blood thinners. And so if the patient take blood thinners, you can have less traumatic extraction. You can suture the area and let the patient wait in the waiting room, and check on them after an hour or two and see if the blood clot is there and it's organized and there's no bleeding. Just let them go. But in general, if they have bleeding, you have if they come in the second day and they have bleeding, you have to clean the area, because there's a very large blood clot, and they call liver clot. You just clean it and see where's the source of the bleeding, and you can always anesthetize the area and clean it. Sometimes you can see there's a tear in the floor of the mouth. Usually that's happens the floor of the mouth. There's damage, and you don't know, and the patient doesn't know because it's anesthetized. And you can see some area damage. You can just stitch it, or you can put pressure on it. And usually, if the patient doesn't have any systemic disease, the bleeding will stop. Almost always the bleeding will stop with the pressure. And because of the socket, you can fill the socket with Surgiseal or special sponge that stop the bleeding. And if you're lucky enough, you have bone graft, and you can do surgical. You fill the bone graft, and you do biological membrane to protect that blood clot, and you can stitch it. It will help a lot in stopping the bleeding. Swelling or bruising can happen, especially if you work around the mental area, mental nerve, and mental artery here, a mental vein. And sometimes if you use the multiple injection, sometimes one of the injection can damage one of the major vessels. But bruising and swelling can be treated by educating the patient, tell the patient is okay, it's going to be disappear within a few days. And you can use cold pack in the first few days, because cold packs will reduce the vascularity of the blood vessels and reduce the bleeding in this area, because that will be bleeding inside the tissue. And after the fourth or third day, because of the areas of swelling, you can use warm compress, but you want the drainage of that, and that's bleeding inside the tissue. And sometimes injury to the nerves, and the most common nerve to be injured is the inferior nerve, and the end part of it is the mental nerve. Usually will never happen in younger person. Usually happen with older person when there's there's resorption of, especially you work in the premolar area and the lower premolar, and the tooth is fractured, and you use a lot of elevator, a lot of force, and you remove the bone. There's a chance of damaging the inferior alveolar nerve, especially mental nerve. Or sometimes we work with the wisdom teeth, and you try to cut the wisdom teeth and the roots around the root of the wisdom tooth around the inferior alveolar nerve. In general, just take X-ray. If you have a 380 X-ray, you can see it before. And sometimes the swelling of the oedema around the tissue after because of traumatic extraction can cause pressure on the nerve and cause numbness or injury to the. Rarely can cause paresthesia or pain in the area. Usually, will numbness. And it happens with traumatic extraction, especially in the premolar area. Alveolar bone fracture is one of the common complications, happen with too much force. If you're rushed to extract the tooth, if you damage the adjacent structure or damage avulse the gum. And so you have to study the case. This picture of fractured canine. The canine have very large, long roots, and the root usually is not cylindrical. So sometimes some dentists, they try to rotate the canine and get a fracture. And if you want to extract multiple teeth, I rather, my experience, extract the canine first, then extract the premolars and lateral incisor after that. Because sometimes if you want to extract the whole segment, extract the lateral and the premolar, and you try to extract the canine, almost always the buccal plate attached to the canine and comes with that. It happens with the first molar too. The first molar is a large one of the, it's the largest tooth, upper first molar. Sometimes when they extract the first upper molar, the buccal plate comes with it. So always protect don't rush. Try to separate the tooth and make a movement, and don't push too much. When there's a pressure, if you see pressure, if you use the forceps. If you use pressure, don't do too much pressure. And if you use too much pressure, that's by the way, if you extract a lot of bone, you will have a prosthetic challenge. If you have prosthetic challenge, very difficult to be treated with a bridge or implant. You have to do it with partial denture. The other complication is tuberosity, fractured tuberosity. I know if in younger people, when extract upper wisdom tooth, sometimes we just put elevator mesial to the wisdom tooth. The wisdom tooth will immediately be extracted. But in older patient, the bone will be thicker, and the maxillary sinus will grow by itself, will take space from the bone, and too much pressure on this area, it's very chance of fracturing the tuberosity if we extract the wisdom tooth or extracting the second molars, and especially in older people, and you don't want to get that complication. And sometimes it's a fracture, and you can see the buccal bone extracted, but it's still attached with the tissue. And when you try to remove it, it will lift down all the tissue and goes to the palatal tissue. So whenever you have extraction and you got the tooth loose, but you can see the buccal plate still connected to the tooth, you should stop and look, clean, and and clean the area. And sometimes if when you have fractured tuberosity, you will have damage to there's a major nerves and arteries, superior alveolar nerve and superior alveolar arteries behind the tuberosity. You don't want to get damage to that, and there's a lot of bleeding. Also, the sinus, sometimes when you fracture tuberosity, you have oral-enteral communication and can cause a complication for you. You don't want it. So study the case. Don't use too much pressure. If you can see this case, just call, refer. Sometimes you can stabilize the area by wiring or a sex retainer, and use the hand piece to remove the occlusion from the lower, so we have less trauma. And if you stabilize the tissue and send it to your specialist, and prevention is much important than having this case. You don't want to get fractured tuberosity. Damage to the adjacent teeth. If the adjacent tooth has a crown or big filling, you don't want to get that. It's not good for you. The patient will never respect you if you damage the adjacent tooth, and it will. So gel-widths, be careful to the teeth. Don't look on just one tooth. Look at adjacent teeth, lower teeth. Look at the palate. Never work on the palatal side. Use elevator on the palate side. Always use buccal. Always how you can use your fingers of protection. Don't use too much pressure on the area. See what you do. You always look what you do. If you use your mirror, use your if you have loops, you have glasses, always light the area. So this traumatic extraction, this case of the premolar, this premolar with the root canal. Almost always teeth with root canal are very difficult to be treated because the dentin is dry and brittle. The enamel is always brittle, but the dentin will, if a living dentin, will give you cushioning to the enamel. So when you try to extract a failed root canal tooth, it's almost always there's a chance of fracture or brittle. So this patient, the dentist tried to extract it, end up using a lot of handpiece, removing a lot of bone, a lot of damage, and to be damage to the adjacent bones the bone that support the first premolar and the first molar, and it's going to end up with periodontal disease, and and the chance of replacing this with implant is almost none. And this is it's very sad complication. If you have very gentle and take your time and study the case, and even you can study the case and discuss the patient, you can do implant. If you have a good bone, you can do immediate implant, because if you have very clean socket, you protect the crystal bone, and you can do immediate implant. Sinus perforation or enteral communication happens usually upper first molar, but second premolar and the second molar can happen too. Always take X-ray. If you have a 3-day X-ray, you can see where's if there's an abscess, and it eventually can tell if there is a sinus damage. Sometime when you extract the tooth, upper molar, there will be oral-enteral communication, but the dentist doesn't know and the patient doesn't know. But fortunately, the blood clot will protect that and will heal. And sometimes, if you have oral-enteral communication, don't scrap too much, because you might make the oral-enteral communication bigger. So if you think there's something, you protect the blood clot. Suture the blood clot, give the patient sinus instruction. Don't blow through your nose. Give them antibiotic and stitch the area and fill this with surgery, fill the socket, and see the patient after 3 days and next week, and take X-ray. It's give you peace of mind, and but just be careful. If you have a good diagnosis, it would help you, because you can take X-ray before extraction. And if you think if you extract the tooth and you will have oral-enteral communication, just refer it to your specialist, and your teachers will help you. TMJ, if you have too much pressure on the lower jaw, TMJ can go. If you have a long procedure, if you think if the extraction will take longer for hours and hours, almost always there's there's pressure on the joint, pressure on the ligament, the periodontal ligament, on the TMJ ligament around it, and it can be avoided with less pressure. Let the patient rest. And there's a biting block. So if you extract this area, there's a bite block. You can put it on the other side, and let the patient bite on this side while they do force, and always support the mandible when you put too much pressure on when you extract. Use non-dominant hand to support the mandible when you extract it. Delay healing and bone sequestration happen. This patient has radiation. If you study the case before extraction, if you think you will have complication, you could refer it to the oral surgeon or the hospital clinic. and you can follow the patient. He will not going to lose the patient. The patient will respect you because you care about them. You don't because you refer them to your specialist. So always be careful when extract when the patient, especially if they have radiation. Osteoid necrosis is very difficult to treat because the patient is already, the bone is already sequestrated under the gum. So try to avoid that condition. Granulation tissue and abscess, especially when if you're thinking of doing implant, you have to clean the socket, irrigate the area. When you see clean, fresh blood from the area, then you put blood. You can put Surgisil, or you can suture the area. And this case is almost like a cyst associated with the root. Always remove any fragment of bone. And don't damage the gum. The gum, one of the source of bleeding after extraction, is damaging to the tissue, to the gingiva, or damage to the free gingiva or attached gingiva. So almost always try to put the pressure between the periodontal ligament and the bone and pushing the tooth away without just severing the bone, the tooth from the bone, from the periodontal ligament. And as much as you take your time, don't traumatize the area. Postoperative instruction, always tell the patient it's not gonna be painkiller. There's nothing said. There's no pain. There will be a little pain, but you will help the pain with medication, and you can give the medication to reduce the pain, reduce the swelling, give them ice pack, give them support, and tell them you're there. If they need anything, they can call you, and you can see them after a few days. And the patient needs your support. You need your help, and it's your patient and your reputation. You want to build your patient. You want them to come back. They want them to bring their family back. If you treat them well, if you respect them, and you treat them like one of your family. Good oral hygiene, the good oral hygiene, and the wound heal. That's as you can do it with print, give it to the patient as a printed instruction, or sometimes you can have a video for them. They can watch it while they're waiting for you, and your assistant can tell them what they can do, and you can give them a little ice pack with your name on it. It's help and as a respect for your patient, and they will like that. Almost always give them your phone number or give them office phone number, because you don't let the patient in the dark and you extract the tooth and let them go away. No, you can give them like a chance to sometimes they just want to talk, or they just want to they have concern or something, they think about it. So it never hurt if they give them your number or your phone number of your assistant or your office. So I just want to tell you in conclusion, just be careful, relax, don't rush, take your time, study the case. Extraction is not a force, and just take care of your patient and think about the future, because you want to build your reputation and you build your patient referral system. And I guess thank you very much. Let me know if you have any question. Sorry if I take too much.
Dr. Jany, for the thorough explanation. Let's move on to the discussion session. To all the audience, you are welcome to ask any question to Dr. Jany. Please raise your hand. Maybe while waiting for any question from the audience, I would like to ask question to you, Dr. Jany, regarding you said before, you mentioned about root fracture during the dental extraction. From your experience, if there's any root fracture happen, would you recommend to leave the remaining root, or would you go and continue the extraction until all the fragment is extracted?
Okay, so first thing you think is the tooth is infected or not. If it's infected, you have to remove it. The second, if you think you can do it, you can extract the tooth without damaging the bone or damaging adjacent structure, just do it. And I think before you fracture the root, think about how to, you never grasp the crown, you have to grasp the root. And try to remove the tooth, make a little mobility with your luxator, periodontal, odontotome, and use a smaller instrument and push between the bone and the tooth, not between the two teeth. And we have, when you have a little mobility, now you can use the forceps, or some dentists nowadays, they hate the forceps because the forceps can damage, but but most of the dentists, they use forceps. But you can use a little bit of mobility. When you have a little mobility, the root is mobile. And even if the crown is fractured, the root is a little have mobility. And there, sometimes you can make a little groove in the root, and you can use the smaller elevator, go to that groove, and you flip it. So, and if you can make it, but if you think you're gonna make damage, you cannot make it, just refer it to the oral surgeon of one of your teacher.
Okay. So no rushing in doing the extraction.
Yeah, don't rush. That's, take your time. Take X-ray. You can see where's the root, where's the curvature, and sometimes some people they say there's root and tooth ankylosis. It's very rare that tooth be ankylosed in bone, so all the teeth can be extracted.
Yeah. Maybe any question from the audience? We have three classes of international unit program here in our faculty, Doctor.
All right.
Maybe another question is regarding the antibiotic use after dental extraction. Here in Indonesia, there's still many dentists that tend to give antibiotics after dental extraction, just because the fear of infection, not because there's any infection already perceived, but there's just the fear for having
just
any
prophylactic. Prophylactic, yeah. Just prophylactic. Look, almost always all infection, when you extract the tooth, it will drain. The chance of infection will be is very low, because you extract the tooth to drain, especially if you have a clean extraction and you clean the granulation tissue. The chance of infection, and the patient is healthy, you have less chance of infection. So but if there's other indication, if the patient have medically compromised, diabetic, have kidney disease, and they taken corticosteroid, so that you can give them antibiotic. If the socket is infected, if the periodontal disease, if there's that oral cavity is very infected, there's calculus and stuff, that's give them antibiotic. You don't want to get infection. So it depends on the case, but almost always when you extract the tooth, there's a drainage. We have less chance of infection, but sometimes infection happen, and infection can happen through I told you this case by injection. The anesthesia injection can cause infection too.
Thank you, Doctor. Please, all the students, is there any question? Maybe very interesting, because maybe dental extraction is not one of the topics that our students are already familiar with, because during the bachelor program, most of the practice that they do is about preparation for the cavity and conservative procedure.
Chloe. Hello, Chloe.
Hi, Doctor.
Yes.
Excuse me, Doctor. First of all, I would like to say thank you for your time and for your presentation. I found it very interesting. My name is Chloe. I'm a second-year dental student, and I was wondering about what you said previously about historically it was recommended to squeeze the socket after tooth extraction, if I'm not mistaken, but it's not longer recommended now. So my question is why that is. Thank you, Doctor.
Okay. So when you squeeze it, you fracture the cortical plate. That's cortical plate. That's called green stick fracture, and make it. And nowadays, I told you now, the long time ago, before the implant, we think of partial denture. We never think about the implant. Now we think about we're going to do implant. We keep the bone. As much bone you have, thick bone is good for your implant. if you squeeze it, make it smaller, you will have less chance of have a smaller bone. And always think, what are you going to replace that tooth with? And one of the best replacement is implant. And before when you think about before that, they think of partial denture. We squeeze the area so we have less undercut, and it will be easier to have partial denture. But nowadays we have the chance of we can do implant, so we can fill it with bone graft without, and fill the whole socket, and you can suture it, and you can use membrane, and the whole area will become new bone, and for your future treatment of implant. So when you squeeze the socket, you have a smaller amount of bone. And and when you think about implant, you're going to make a thinner implant or smaller implant. And I hate mini implant because as implant, we need the force, because we need a thicker implant, give you more strength and more attachment or more osseointegration. Thank you.
Any other question, maybe?
As long as you're a dentist, you're gonna have extraction. You're gonna have to learn extraction. It's one of the common thing, and it's you have to ask question now, because it's very difficult for you when you have your own practice and you have a difficult extraction. It's very difficult to call somebody to help you. I'm oral surgeon. My friend, she's a prosthodontist. We have our office in the same area. So she called me and she don't send the patient. When I have a complication, she called me. I leave my patient. I go see her, and I will to tell them. It's very difficult for her to call me, and when she have complicated the fracture, although she is a specialist prosthodontist, but it can happen to everybody, and no one always a tooth very difficult to be extract, and you need you to learn. Take your time, study the case, and don't look for just one tooth. Look at the patient as a whole. People are like thick and they have large bone, and they are in the 40, 50 years old. They are more difficult if you have a younger patient, very thin bone. So you need to build up your confidence, your education, and you can do it now under your supervision of your teacher. Your teacher will help you. Do separation, do sectioning, do suturing. I want you to learn suturing. I learn to do sectioning of the tooth. And you take your time and learn, less damage to the tissue, and look for the future of your practice.
Maybe one last question, Dr. Jany, regarding the wall flow that you mentioned before about the bone will be weakened if there's no load on the bone. How soon would you suggest or would you recommend for a denture to be put after a dental extraction?
Okay. Well, if you care of the patient, take compression before extraction. You can do immediate denture. So if you think of the patient, you can discuss with them, and if the patient who likes you, especially if female patient and she works on the bank or something, she don't want to live without the tooth, especially anterior. So you can take compression before extraction, prepare a simple partial denture or flexible partial denture. And if you have a dental lab technician, can make it within hours before extraction, and immediately when extract the tooth, you have a partial denture. This partial denture will help the patient smile. This partial denture will protect the blood clot, will help in healing. So if you can do immediate partial denture, immediate replacement, will help in your healing, and also will guide the healing and protect the blood clot. And you will have less chance of dry socket. And the patient will like it a lot because they don't want to go out without the tooth.
Thank you very much, Dr. Jany, for the explanation. Maybe if there's no more questions that need to be asked.
Dr. Farah, may I?
Yeah. Okay. Dr. Zaki, please.
It was an interesting lecture, Dr. Saleh Jany. Perhaps me as an oral medicine specialist who is not doing the extraction anymore, but I'm interested to the post-extraction instruction you just mentioned. you wrote that we should instruct them to rinse with chamomile tea. Is there any particular reason?
The tea. No, the tea has tannic acid. So one of the theories, tannic acid will help in blood clotting. Some tea bags, the tea has a tannic acid. But nowadays there's Surgisil, there's other ready-made can be added as a clotting factor. But long time ago, they can use tea leaf or tea bags because the tannic acid inside the tea will help blood clot. That's in the books. So that's some of these books that they can use it. But nowadays, it's other things can be available. And if you have severe bleeding, just give anesthesia, because first to give anesthesia. Some people, they said, don't give anesthesia because vasoconstrictor will mask the bleeding. I said, no, you can give them anesthesia to make the patient comfortable because the patient is already scared. So give them anesthesia, the blood pressure go down, talk to them, look for the bleeding, usual the bleeding because damage of the tissue, damage to the gum. Clean the area, stitch it, put a special dressing on it. When you suture it, and let the patient bite for a gauze or something, and let them wait for 40 minutes, the bleeding will stop. And that's one theory of the bleeding. And stop bleeding, post-operative bleeding.
Okay, thank you, Doctor.
Thank you.
Okay, thank you, Dr. Zakia. Another question from Alisa.
Good morning, doctor, or maybe it's in the afternoon there.
It's the evening. It's almost 10 o'clock in the evening.
My name is Alsa Chalanta Alvin. I am a second-year dental student, like Chloe. Before going to my question, I would like to thank you, doctor, for giving us the lecture. It's very insightful. Let me go to my questions. I'm new to this, so I'm sorry if I make any mistake, but previously you've mentioned regarding bone graft. For every tooth extraction, is it essential for a doctor to do a bone graft, or is it only indicated for some situations? And could you please maybe explain the overview, why is a bone graft needed for tooth extractions? Thank you, doctor.
Thank you, Lisa. So, what do you think when you're gonna replace that tooth? So the best treatment or the rest replacement is with implant. When we need the implant, we need good bone. So bone graft, when you fill this area, you put the bone graft, and the bone graft will help the bone grow. Imagine this is the socket. This is the socket. When you extract the tooth, it will the socket will shrink because granulation tissue grow faster than the bone tissue, than osteo tissue. So we have less bone, and the area shrinks. So maybe if you have somebody in your family extract a tooth, and without replacement, you can see there's a shrink. There's go down. The bone is very small. If you fill that with bone graft, and you build a special membrane and you stitch it, you have good bone for future treatment. But although it is a little bit more expensive, and I don't think it's a surgical difficulty for a dentist, it's just to clean the area. Bone graft, they are ready-made bone graft, and you can fill it in the area, and with time you learn how to suture. You can suture the area to scaffold the area, and if you have membrane, it's the same. You will learn your muscles to do the suturing, and once you do it, you learn to do it forever. So don't scare. That's work. Ask your teachers. They will help you how to learn these things. So bone graft is indicated, although it's expensive, but it's one of the indication for future treatment. Even if you don't want to do an implant, when you do denture, when you have good bone, the denture will have more support, more retention if you have a good bone. You can see people with denture, when they have good bone, they have more retention, more stability, and if they have flat bone, they will have loose denture. So whenever you can protect the bone or you grow the bone, it helps for a future treatment. But although it's a little bit more expensive, a little procedure longer, but you have to learn to do it because it's for the future. You can build and you can make more implant cases.
Thank you, doctor, for your answer.
Another question maybe from the audience? Dr. Saleh Jany, maybe thank you very much for your explanation and your time for us here in Indonesia. Before we end our discussion and lectures today, from the faculty, we would like to give you a certificate, the word, maybe from Dr. Asti.
Hello, Dr. Saleh Jany. Thank you for lecture today, Doctor. I think I believe our IUP students really enjoy the lecture and get totally knowledge from you. Thank you very much.
Makasih.
Yeah. Sertifikat Pak Adam bisa di-share.
This is a certificate of appreciation to Dr. Saleh Jany. Thank you very much, Doctor.
Thank you.
Thank you for lecture today, Doctor.
Thank you.
Thank you, Dr. Asti.
Thank you, Dr. Farah.
Before we end our question for all the students, we have a post-test question that you need to fill. The link will be given to you in the screen. Ada, boleh ditampilkan lagi link untuk post-testnya. All the students, you can answer all the questions. And to Dr. Saleh Jany, once again, thank you very much. Let's give a round of applause to Dr. Saleh Jany. Okay. Let's end our lectures today. Thank you very much to Dr. Dewi and Dr. Asti and also Dr. Saleh Jany and all the audience. From me, I'll end the lectures today. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
Thank you, Dr. Saleh Jany. The certificate will be sent to your email as well from our staff. Thank you.
Thank you. Thank you.
Dr. Farah, thank you.
Thank you, Dr. Zakia.
Dr. Farah, thank you.
Thank you very much.
Sama-sama, Dr. Asti.
Sama-sama.
You have 3 more minutes to finish the question. Okay, the time is up. Thank you very much to all the audience for joining our lectures today. Don't forget to fill the attendance form, and thank you, Dr. Asti, for the opportunity. I would like to end this lecture today. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam, Dr. Farah. Thank you, Dr. Farah, and to all your students. Our students.
Kami Dr. Asti. Assalamualaikum.
Assalamualaikum. Izin pamit. Pada makasih.